Hello, good afternoon, everyone. I think I might start a couple of minutes early in order to leave some more time for questions. I do want to thank the NKF and thank the sponsor because this program is supported by an educational grant from AstraZeneca. So my name is Linda Freed. I am based at the University of Pittsburgh and the Pittsburgh VA. I'm a professor of medicine. My research with hyperkalemia is actually secondary. It was much more part because I chaired VA Nephron D, and which was dual ACE and ARB. So practically, we had a lot of hyperkalemia. It's actually one of the main adverse outcomes of our study, and thus we had to figure out how to practically manage it in order to do the study. I also do a lot of clinical care and am working on sort of a VA-funded quality improvement program in order to increase use of SGLT2s, GLP-1s, ACE inhibitors, and those with CKD. So I will give the case presentation and the first talk. The second talk will be from Annabelle Burette, who is an assistant professor and a registered dietitian in the Department of Nutrition Science at Purdue and an adjunct professor in nephrology at Indiana University. So her broad interest is in nutrition and kidney disease, and she aims to study the effect of nutritional and pharmacologic therapies for chronic CKD, and focusing on the gastrointestinal tract and the gut microbiome. I'll give a plug that she has a talk tomorrow on this as well. Additionally, she is interested in improving outcomes in the Hispanic Latino community with CKD, and looking at language and culturally concordant lifestyle interventions. Our third talk will be by Dr. Bruce Spinowitz, who's an associate director of nephrology and vice chair of the Department of Medicine at New York Presbyterian Queens. He's a professor of clinical medicine at Weill Medical College of Cornell. He's and vice chair of the Department of Medicine at the New York Hospital Queens, also director of a lot of roles, director of nephrology and dialysis service at the hospital. Trude Weisskopf Memorial Satellite. He is a professor of clinical medicine, and his internal medicine training was also in New York, and he has done a lot of work on anemia, on potassium. He does peritoneal dialysis, and has a lot of expertise in using these medications. So I am going to just move on. So here are my disclosures. I sit on a number of data safety monitoring boards, and I have some research support from AstraZeneca. I don't get money personally, but this is for research. So the overall learning objectives from my talk will be to review the physiology, pathophysiology, and epidemiology of hyperkalemia and CKD. The second talk will be to describe effective dietary interventions that prioritize cardiorenal protection and the prevention of the development of hyperkalemia. And then the third talk will summarize the impact of newer potassium binders on clinical outcomes. So next will be our case presentation. So you were asked to see a 55-year-old male with type 2 diabetes, hypertension, and heart failure with reduced EF and diabetic kidney disease for AKI and hyperkalemia. He presented to the emergency room with cough, myalgias, fever, and a poor appetite. His outpatient medications are lisinopril, bumetanide, carvedilol, dapagliflozin, amlodipine, and atorvastatin. His blood pressure in the ER is 110/80. His heart rate is 105. He has dry mucous membranes that should be and no edema, should be regular rhythm. His labs are notable for a sodium of 136, a potassium of 6.4, bicarbonate of 20, BUN of 85 and a creatinine of 2.4. You review his prior outpatient labs in the medical record, and his baseline creatinine is 1.5, which corresponds to an eGFR of 55. He has urine albumin to creatinine of 450 milligrams per gram, and his most recent outpatient potassium was 4.9. This is his outpatient EKG. This is his prior EKG. It looks pretty normal. And you can see here, this is his EKG in the emergency room, and you can see quite clearly peak T waves, though he still has a normal PR interval and a normal QRS. So hospital course, he is treated with IV fluids, insulin, glucose, albuterol, and sodium zirconium cyclosilicate. Losartan, SGLT2 inhibitors, and diuretics are held. His nasal swab is positive for influenza A, and he's admitted overnight for observation and continued IV fluids. On discharge, his potassium has improved to 5.2, his BUN is 55, his creatinine is 1.7. He is scheduled to see you in a follow-up appointment. Lisinopril, bumetanide, and dapagliflozin are not restarted on discharge, but he is discharged on a low potassium diet. His primary care doctor saw him 1 week later, and due to edema, restarts the bumetanide. 2 weeks after discharge, you see him in the office. His potassium level is returned to 4.9. His creatinine has returned to 1.5. His blood pressure is 150 over 80, and he now has trace edema on exam. Oops. So the real question is going to be, what medication do you restart? And I'm going to ask you now to go to your app and answer this question. Do you start none of them? Continue to hold the lisinopril and dapagliflozin? Do you restart the lisinopril? Do you restart dapagliflozin only or lisinopril? Oh, I see. It's in real time.
Listen, sometimes it takes months to elect the president of the United States.
Still changing a little bit, so I'll wait till it no longer changes.
Okay. We're good. Under 13. So that's the appearance. I think the vote is in. Two people are still eating their cake.
It looks fairly stable, so I will move on. So there is no, I would say, probable right answer, but if you ask my opinion, you should be restarting both. Remember, this is a patient who has heart failure with a low ejection fraction. So from a mortality point of view, he should be on both medications. These medications also both slow progression of kidney disease in individuals with diabetes and proteinuric disease. So I think they should both be restarted, but you do need to follow, in particular, that potassium. It does show us that he, is at risk for recurrent hyperkalemia. So I'm now going to switch from the case presentation to my talk. I'm going to talk a little bit about potassium balance, the epidemiology of hyperkalemia, and some of the risks associated with hyperkalemia. So 98% of the body's potassium is intracellular, with only a fraction in the plasma or intracellular fluid. And you can think of the serum potassium being controlled by two processes, external balance, which is what do you take in and what do you put out, and internal balance, which is the distribution of potassium between the intracellular and extracellular compartments. Treatment of a hyperkalemia, particularly acute hyperkalemia, is directed at both. So this is just giving you a sort of diagrammatic picture of that. You have, obviously, the intake in your diet, excretion, which is generally kidney, but could be a little bit from the gut, controlling your serum potassium level, and then you have this internal balance between the extracellular and intracellular compartment. So you can categorize mechanisms of sort of potassium homeostasis where you, in terms of intake, the body senses potassium in the GI tract. It also senses extracellular potassium concentration, and it regulates the distribution of potassium between the extracellular and intracellular compartments, and you also have potassium excretion. A complicated diagram, and a lot of the mechanisms are not completely known, but it's recognized that if you've taken a potassium-rich meal, it is identified in the intestine, though we don't know all the sensors. It's also identified in the pancreas, and you increase insulin to help move potassium out of the cells. And you have, again, with the rise in extracellular potassium, you have an increase in aldosterone, insulin, and other sort of markers to lead to uptake of potassium into the cells, mainly muscle, as well as ultimately excretion in the kidney, though this takes longer than this. So in terms of external balance, though, your intake, 50 to 150 millimoles per day on average. There also need to consider that, particularly I mentioned this patient has heart failure. If somebody told him a low-salt diet, but he really likes the taste of salt, he may have reached for, let's say, some of the brands of salt substitutes, and many of those are potassium chloride. As well as you might be giving medications that have potassium in them. And then you have excretion. 90% of the excretion is renal. And then you have extrarenal, which can be a small amount through the skin and sweat or in the GI tract. So if we think about what promotes potassium excretion in the kidney, and that will also influence how I can promote potassium excretion in somebody who has hyperkalemia. Obviously, GFR is important. Higher tubular flow rate, increased urine flow. Higher distal delivery of sodium. So not surprisingly, diuretics, loop diuretics, that increase distal delivery of sodium, increase tubular flow, help, are commonly, in those without CKD, associated with hypokalemia, aldosterone, and then non-reabsorbable anions, though not that common outside of certain medications. So what it causes hyperkalemia? You could have excessive potassium intake. You have or decreased renal excretion. And this can happen because GFR is low. Decreased distal tubular flow. So remember, in volume depletion or CHF, you have increased proximal reabsorption of sodium and potassium, and you decrease distal delivery of sodium. You also decrease urine flow rate. You can have mineralocorticoid deficiency, or you can have distal tubular function, the part of the kidney involved in potassium homeostasis. And you commonly see this in diabetes. That's the type 4 RTA you commonly see. You also, in a lot of our patients, commonly see this with the damage you see with urinary retention. A number of glomerular diseases can also, let's say lupus, can also have a interstitial nephritis component. If you have a chronic interstitial nephritis component of the GN, you can also see hyperkalemia. I mentioned potassium intake, but that is very hard to do alone. You generally cannot take in most of the time enough potassium orally to cause hyperkalemia in the absence of impaired excretion. So you really do need both. However, there are, a number of our patients have CKD, and also, a number of the patients, we're just going to talk a little bit more about heart failure, but a number of the medications that are used to decrease adverse outcomes impair potassium excretion. So when the potassium excretion is impaired, at that point, if you have increased potassium intake, you increase your risk of hyperkalemia. And then obviously at the extreme, if you think about our dialysis patients with no urine output, they're much more likely to have hyperkalemia. So the medications that increase the risk of hyperkalemia, there are a number of them, but these are the most common, are nonsteroidals and COX-2 inhibitors, the RAS blockade, mineralocorticoid receptor antagonists, potassium-sparing diuretics, beta blockers that influence the shift of potassium into and outside of the cells, calcineurin inhibitors, so this is common in, say, transplant patients, heparin, and trimethoprim, particularly in high doses. So I'm going to switch to the epidemiology of hyperkalemia. So this, the CKD Prognosis Consortium is a study that had 27 international cohorts. Some were CKD, some were cardiovascular, and some were general population. Large number of individuals, and at baseline, the prevalence of a potassium level greater than 5 millimoles per liter was 3.3%, and greater than 5.5 was very low at only 0.5%. And you can see from a population point of view, there is a pretty sort of normal distribution of potassium levels, though there is this tail over here. But if you divide the group up into EGFR levels, you can see that there are really three curves. The normal population is really, their mean is really in the normal range. And as GFR drops, the curve shifts with more and more patients having higher levels of potassium. So if we think about what is the prevalence of hyperkalemia in our patients who are on sort of, let's say, therapy, we can start looking at some of the older studies. So in Renal, remember this was a study evaluating ARB in individuals with diabetes and proteinuria. They had no stated inclusion-exclusion criteria based on potassium. But despite the sort of very high risk of a potassium greater than 5 on the study drugs, over 35%, only 1% approximately of the individuals stopped the medications for hyperkalemia. So they did still continue the patients on. And you can see here potassium greater than 5.5 occurred in about 10%, so fairly common. So who gets hyperkalemia? So this is a study from a population-based study from Stockholm looking at all adults who have care in Stockholm and who had a potassium measurement. It's over 350,000. They were followed for 3 years. They looked at potassiums greater than 5 or 5.5. And hyperkalemia occurred in 7%, but importantly for our patients clinically and also for the rest of this talk, if you had hyperkalemia, about a third recurred. So what hyperkalemia can tell us, and particularly mild hyperkalemia increases the risk of more advanced hyperkalemia, is if you have it once, you are very likely to have it again. And what were the risk factors? Older age, which might be a reflection of underlying kidney disease, diabetes, lower EGFR, cardiovascular disease, and use of RAS blockade. Lower risk were women, younger age, higher eGFR, and the use of diuretics. And this is sort of, you can see, diagrammatically each of the risks, and you can see here, here's, the GFR. Here is stage 4 CKD. So the dark bars, just to orient you, the dark bars are potassium greater than 5. The gray lighter bars are greater than 5.5. And so not surprising, here's age, again, increasing across age groups, increasing as GFR stage worsens. Again, diabetes, MI, CHF, and RAS blockade. As I mentioned before, our dialysis patients have a high risk of hyperkalemia, and in this case, kidney elimination of potassium is minimal in our patients. And potassium levels are typically maintained by dietary restriction and removal of potassium. It's mainly based on diffusion, and the amount removed correlates with the serum dialysate concentration. So, if you start dialysis at a potassium of 5.5, most commonly used in the United States is a dialysate potassium of 2, the gradient is 2 to 5.5. But if you use 1K, which we don't use that often because of the potential risk of arrhythmias, but what you can see is with start of dialysis, you come down. These are individuals who started a little bit lower, a little bit higher. They come down, and then after dialysis, it rebounds in the first few hours after dialysis, and then, up till you get to the next dialysis treatment. So hyperkalemia is common. If you use, in this case, in dialysis patients, using a potassium level greater than 5.5 rather than 5. The prevalence is approximately 16 events per 100 persons months are common. It's not surprisingly, it's more common on that 3-day stretch. So if you got your labs on Monday or Tuesday, you're more likely to see the hyperkalemia than midweek. And if your dialysis level is a little bit shorter, so you can have that, so longer. It's more common in younger patients, which could reflect diet, but it is associated with mortality. And the lowest mortality is a potassium level associated with 4.6 to 5.3. So on the upper end of normal to what we might consider to be slightly above normal. So what are the risks of hyperkalemia? So hyperkalemia is associated with an increased risk of death or increased risk of dialysis, an increased risk of adverse outcomes. However, it's hard to tease out whether or not this is a direct relationship or it's due to, due to the comorbidities that are associated with, let's say, the adverse, you have adverse cardiac outcomes. Is that because you have worse cardiovascular disease? Or is it due perhaps to the fact that we discontinue the medications like we did in our case study? The person has a known history of heart failure and a low EF, which is associated with increased risk of death itself. Medications decrease risk is the increased risk of hyperkalemia because you stopped the meds. Obviously, there are people who get death from hyperkalemia. Just to briefly review what you see in an EKG, initially you'll get, that prominent, this is hypokalemia, you get a prominent T wave, that peaking that I showed you on that first EKG. At time, you'll start losing your PR, you'll get PR, increased PR interval, widening of the QRS until you get the dreaded sine wave, which looks like this. In this case, it's sort of hard. You can just see the widening of the QRS and the sine wave, which is obviously fatal. If we, as I looked, I mentioned the CKD Prognosis Consortium before, and if you look at the outcomes associated with potassium levels, it's U-shaped. You don't, low potassium is associated with adverse outcomes and death, and so is high potassium, with this normal range being the best. Associated with increased risk of ESRD, a little bit more, not as obvious a shape here with cardiovascular mortality. And I mentioned that, but as I said, is the outcome related to those arrhythmias that I showed you, that sine wave, or is it related to stopping the drugs that are beneficial? So this is a retrospective study, from England. They had individuals who had heart failure and had hyperkalemia, and the potassium level was greater than 5, and 32% had their RAS inhibitors stopped. Not too surprisingly, the worse of the higher the potassium, the more likely you have stopped the RAS blockade. However, if you did stop, there was a higher risk of mortality. So all these people had hyperkalemia, but if you stopped the drug, you had a higher risk of mortality in the 1-year follow-up. So in summary, 98% of potassium is intracellular, and potassium level in the serum is defined by that internal balance, that shift between extracellular and intracellular compartments. I didn't really give you that much data since this session is focused more on chronic hyperkalemia, but remember, how do you treat acute hyperkalemia? It's with insulin and glucose, albuterol, maybe bicarbonate, but that's again to shift between cells. And then external balance is that intake versus excretion. And our treatments are directed at both, often decreased potassium intake and trying to promote excretion. The incidence of hyperkalemia increases with lower eGFR, diabetes, cardiac disease, and the use of RAS blockade. But hyperkalemia is associated with increased mortality. However, discontinuation of RAS blockade is common and is also associated with mortality. And our future talk, first, I'm going to turn this over to Annabelle to talk about some of the dietary issues, and then Bruce will talk more about treatment. I have to go back to sessions. Okay. Here. Okay. Okay.
Hello, my name is Annabelle Viruete, and it is a true honor to be here representing dietitians in this session. So the question that I'm hoping to answer is, can patients with chronic kidney disease eat a healthy and avoid hyperkalemia? These are my disclosures. And as Dr. Fred mentioned, I'm going to be covering that second learning objective, which is to describe effective dietary interventions that prioritize cardiorenal protection and prevent the development of hyperkalemia. So to get us started, I would like you to answer this question. What is the first thing that comes to mind when you think about dietary potassium in chronic kidney disease? I'm actually very curious. I know that we have a mixture of dietitians, nephrologists, nurses, probably social work as well, so let's see. I should have had like Jeopardy music. Oh, bananas. Yay, additives. I really like this word cloud. It actually gives a lot of information for the next few slides. But as you can see, we see one of the main culprits that we think, right? Dietary potassium, bananas, potatoes, tomatoes, avocados. I am from Mexico, so a lot of my diet is here, a lot of beans, etc. So we also have some other things that are gaining traction, like potassium additives, over-restricted, outdated information. So hopefully I'll be able to keep answering some of the questions and going against the restriction. So the outline for my presentation is I will go first through factors influencing the development of hyperkalemia. I will just put in different words what Dr. Fred already mentioned. The relationship between dietary potassium intake and serum potassium in the context of kidney disease. The main question, should we restrict or not restrict dietary potassium in our population? And going into some healthy dietary patterns and potassium management in the context of kidney disease, and hopefully ending with some strategies for the management of dietary potassium in the context of kidney disease. So as I mentioned, this is just another visual representation of what Dr. Fred already mentioned. There are several factors, external and internal factors, that will be affecting that balance and homeostasis of serum potassium. So taking into consideration of the first part, somebody having a meal, maybe a meal that is rich in potassium, some of the potassium will be sensed, some of the potassium will be absorbed primarily in the small intestine, and this is one of the main drivers of postprandial kalemic response, so how much potassium is going to be appearing in blood after a potassium-rich meal. We also have all the potassium that it's not absorbed that will be excreted primarily here in feces. So some of the drivers here could be if a patient has constipation, probably this factor is not going to be not relevant, but important. And also if a patient has already constipation. So this is particularly important in the context of kidney disease because as kidney function starts declining, this adaptive mechanism of colonic excretion takes over, not to the level that we would like to, but it does take some importance here. Once just talking about now the potassium that is absorbed, there's going to be several factors that will be influencing the uptake of this potassium into the cells. So as Dr. Fred mentioned, if we have a carbohydrate-rich meal, we will have the release of insulin that will be enhancing the uptake in the cells of potassium. However, we do have factors, particularly in our population, like metabolic acidosis, muscle wasting, that will be driving potassium leaving the cells and potentially increasing the amount of potassium circulating. Also, if we think about exercise, that also enhances the uptake of potassium by our cells. Then we also have the renal control of homeostasis, and obviously as kidney function starts declining, the amount of potassium that will be excreted in urine will be limited. And also, as Dr. Fred mentioned, if there is the prescription of RAS inhibition, that's also going to limit the amount of potassium that is excreted in urine. So as you can see, there are several factors that will be impacting serum potassium or just circulating levels of potassium. However, for some reason, we tend to think that dietary potassium is the culprit of hyperkalemia. So we think about this just because of the assumption that dietary potassium will be driving serum potassium. However, the data that we currently have is weak at best. There's been studies, particularly epidemiological studies, that have suggested that there's a weak relationship between the amount of potassium that is consumed and the amount of potassium circulating. So this first study was a cohort study in hemodialysis patients, and if you can look at the x-axis is the amount of potassium through diet, and on the y-axis, the serum potassium. So you can see that the range of potassium is pretty broad, all the way from about 500 milligrams per day, all the way to about 4,500 milligrams per day. They found a weak association, so only 14% of the variability in serum potassium was really explained by dietary potassium, but really if you look at the range, from 500 all the way to about 4,500 milligram, there's just like about a 0.3 milliequivalent per deciliter change in serum potassium. Kind of similarly, in another cohort study from the balance-wise study, they found no association between dietary potassium intake and serum potassium concentrations. Now, something also to remember is that the concentrations of serum of potassiums were measuring pre-dialysis. Some patients may be fasting, some patients may already have had some meals before the dialysis session, so there's a lot of variability, really. And also there's been some other cohort studies in non-dialysis populations and in dialysis population, the one that I'm showing here without an image, just with some text. In Brazil and Mexico, they found no relationship between the amount of dietary potassium intake and the pre-dialysis or the fasting levels of serum potassium. So in summary, there's really just a weak relationship of the relationship between dietary potassium and serum potassium. So in the clinic, how do we implement this? And this has been usually, traditionally, I'm thinking about here the traditional renal diet, has been through the restriction of high potassium or potassium-rich foods. And it is probably really likely that if you go to Google or if you Google really dietary potassium and kidney disease, you will find a lot of resources that primarily restrict foods without mentioning of portion sizes, without mentioning preparation of foods or really anything. So it's usually try to avoid these potassium-rich foods, including fruits and vegetables. So going back to our cloud slide, a lot of bananas, melons, oranges, nectarines, kiwi, mango, papaya, etc. A lot of vegetables, and particularly here it comes tomatoes and avocados. These are the things that we usually tend to think about or correlate with potassium, and also some other foods like milk, yogurts, nuts, seeds, whole grain products, etc. However, while low potassium foods were recommended, the intake of other nutrients that are particularly relevant for the handling of potassium are really avoided or not mentioned in a lot of these educational resources that we commonly give our patients with kidney disease. And when I say some other factors in these foods are these factors on the left, which are, for example, dietary fiber. So when we have a patient with kidney disease, it is likely the prevalence of constipation is high, and one of the drivers or the things that we implement to limit constipation is to increase dietary fiber intake. But when we're implementing a low potassium diet, sometimes we actually just in general recommend a low fiber diet. So how does fiber impact potassium handling? Well, in some of these plant-based sources of potassium, they tend to have, we don't have really a lot of data, but they are likely going to have less bioaccessible potassium, meaning that that potassium has the ability to promote less absorption of this potassium. You can kind of think very mimicking the information related to phosphorus and lower phosphorus bioaccessibility or bioavailability in some of these plant-based foods. Also, with an adequate fiber intake, this can increase or promote the fecal excretion of potassium. So this is a benefit for our patients. Also, another thing, if we think particularly in that first category, fruits, yes, they're probably going to be good sources of potassium, but they're also going to be good sources of carbohydrate, driving a release of insulin and driving the cellular uptake of potassium. And also some of the other factors like metabolic acidosis, a lot of our plant-based foods are also going to give us base-forming alkali and trying to limit, increasing the uptake of potassium in the cell, but also limiting the release from the cells. I usually associate acidosis with muscle wasting, and if we have muscle wasting, we're going to have more potassium release into circulation. And also, if you put all of the recommendations together, so remember, our patients are not only probably not going to get recommendations for a low potassium diet, but sometimes it's also low phosphorus, low protein, low everything, very restrictive diet. And if we put everything together, actually, that is not a very cardioprotective diet. And this is just a diagram of the diet that the American Heart Association recommends. So this is really just healthy dietary patterns that usually emphasize the consumption of a lot of the foods that we sometimes oftentimes restrict to our patients, including fruits and vegetables, whole grains, sources of protein, including plant-based proteins like pulses and legumes, nuts and seeds, and also to minimize the consumption of a lot of energy-dense foods, such as foods with added sugars, ultra-processed foods, processed meats, which also are relevant for the handling of potassium because they are likely containing potassium additives that are likely going to have a higher bioaccessibility of that potassium. So in general, if we contrast this cardioprotective diet to or with the recommendations for the handling of potassium, we have first our fruits and vegetables. What do? We oftentimes restrict avocado, oftentimes restrict potatoes and sweet potatoes, carrot, pumpkin, squash, citrus fruits, tomatoes, so very restrictive. Also with whole grains, we may be restricting bran and bran products, partly because of potassium, but mostly because they tend to have a higher phosphorus density with a lower bioaccessibility. We may be also recommending low consumption of dairy because these foods traditionally contain more protein, more phosphorus, and more potassium, and also nuts and legumes. They tend to be restricted from a lot of educational resources, including walnuts and almonds, dried beans and lentils, and seeds. So we're really not promoting a heart-healthy diet in the context of kidney disease. So now kind of like switching gears, and like I said, we have been going from a renal diet that has been traditionally very restrictive to, oh, what if we liberalize the diet? And really the renal nutrition field has been really open about the liberalization of the renal diet. And this has been accompanied by several papers, including our own that was published about 8 years ago, in which we suggested that perhaps we can modify the recommendations to enhance the consumption of a more plant-based diet and really more foods and limiting ultra-processed foods because of the content of a lot of additives, including phosphorus, potassium, and sodium. But obviously we were not the only ones. There's been really a lot of perspectives and reviews like this from Dr. Kalantars today on the Plato diet, here on the liberalization of potassium using plant-based diets, vegetarian diets and chronic kidney disease, the impact of potassium restriction, and the benefits of plant-based diets, and it's now the time to be more flexible and including more sources of potassium-rich foods. But my question to you, do you notice something with all of these papers? And I know that you can't answer, but all of these are really reviews and a lot of perspectives. Unfortunately, we don't have a lot of evidence in interventional trials that have been using plant-based diets in the context of kidney disease, particularly with people either with chronic hyperkalemia or a high risk of hyperkalemia. A lot of the studies that have been done have been in the context of different things like metabolic acidosis. We know the great data from Dr. Wesson and Dr. Baraya. We know some trials with plant-based diets and the gut microbiome, but the primary outcome was not potassium. So we really don't have a lot of information in this end. So is it possible to consume a healthy diet and avoid hyperkalemia? My very biased answer is probably yes. And healthy dietary patterns are relevant for a lot of things. So these are aimed at protecting against chronic diseases such as diabetes, heart disease, stroke, cancer, and obviously also chronic kidney disease. And some of the characteristics of these diets are energy balance, intake of fruits and vegetables and other plant-based foods. We have a variety of healthy dietary patterns. Probably the quintessential one is the Mediterranean diet, but we have several others like the MIND diet, which is kind of the combination of the Mediterranean diet with the DASH diet. The DASH diet that was primarily implemented for the treatment of hypertension, traditional Asian diet, the Nordic diet, traditional Mexican diet, and Latin American diets. And really the Mediterranean diet and the DASH diets have been recommended in guidelines, including Kadoki and Kadigo and some other perspectives in the context of kidney disease. So I'm just going to put here again the diagram, including several factors that control the balance and the homeostasis of potassium. Remember, it's not only diet, but a lot of other factors. So these are my steps, hopefully with kind of like a summary of what we would do, what I would do. One, try to avoid restrictive lists and diets. These probably are only going to create more stress in our population population. And here I'm going to show you some quotes from qualitative studies by Dr. Lily Cervantes in the Latin American population, and also by Dr. Morris from the UK population. In my opinion, these are really sad. So one of the hardest things about dialysis is the diet. I don't eat bananas. I don't eat oranges. My wife gets mad because I ask her for food. She says, well, you cannot eat that. I tell her, but I am hungry. All of the foods that I had to let go because I like avocados, beans, tomatoes, tortillas. I can't handle that. What is left for me to eat now that I have a potassium restriction? So remember, oftentimes it's not only the potassium restriction, but they probably have the recommendation of several other nutrients in the context of kidney disease. And the last one, I find it difficult, particularly social situations are hard. You are at your house, it is very rude to say, I can eat that. I'm not supposed to eat that much potassium. You sound like an idiot. So this also, to me, sometimes as a dietitian, we give recommendations and then we forget about those recommendations. The patients are going to be the ones implementing them. But my perspective was really changed with my grandpa, had kidney disease, underwent very low protein diet, and then we transitioned him to dialysis. So I really saw firsthand the stress that sometimes dietary interventions could put into our patients. So going into step 2, modulate potassium contents in foods. So if you remember those tables of restriction, they completely forget about the serving size, the types of preparation of the foods. So what can we do in order to promote these potassium-rich foods? Limit the portion size. Prepare foods in wet cooking methods, at least at first, in order to see how the patient will react to a higher potassium load. And as I mentioned, I've been mostly focusing on just whole foods, but the reality is that a lot of our population, our patients, are consuming processed and ultra-processed foods. And here I will probably highlight that the amount of potassium additives and phosphorus additives could also be important in these foods, and hopefully we can try to limit those. So I'm just here also showing you a summary from Dr. Capisti, in which they put together all of the foods related to vegetables, fruits, legumes, meats, tuberous root vegetables, and potatoes, and how the processing, particularly by wet cooking methods, can limit the amount of potassium even to the degree of 80% in some of these foods. Step 3, dietary fiber really is one of my most favorite topics. So it's really your friend in the context of kidney disease. So think about that adaptive mechanism, increasing the excretion of potassium through feces. And also thinking that from epi data, we know that dietary fiber intake in patients with kidney disease is low. If we think about the rule of thumb of 14 grams per every 1,000 kilocalories, our patients are consuming about 7. So about 50% of the adequate intake. So it's likely that they're not consuming enough fiber. So these plant-based foods that we tend to restrict are good sources of dietary fiber, and also in general, plant-based foods may have a lower bioaccessibility of that potassium. Think also in the context of metabolic acidosis, so fruits and vegetables primarily are going to be your alkali, aiming to limit metabolic acidosis and also decrease the extracellular output. So now when we're thinking about dietary fiber and maybe thinking some dietary fiber supplements, not all fibers are equal. So if you're wanting to increase the fecal output, think more on your viscous types of dietary fibers, kind of like psyllium and those types of fibers or supplements. So here in this diagram, Dr. Sumida summarized how plant-based diets could be beneficial in the context of potassium handling. And here I'm just obviously showing here the impact of dietary fiber in improving the gut microbiome, but also relevant to potassium homeostasis. And for us, Dr. Fred mentioned, one of my other passion projects is really try to achieve culturally appropriate interventions. So as I mentioned, the quintessential Mediterranean diet, that is probably appropriate, but sometimes it's not really easy to implement in a population in the United States. I live in the Midwest, and olive oil, probably in all the United States, is pretty expensive. So sometimes it's kind of hard to implement these, but know that there are very other dietary patterns that are healthy. So here I'm just showing very similar to the Mediterranean diet, the African diet, and we also recently summarized a dietary pattern for people from Mesoamerica, so Mexico and Central America, which is called Dieta de la Milpa, or Diet of the Cornfield, that promotes the consumption of corn, beans, pumpkins, and chilies, and complemented with a lot of plant-based foods, but also animal-based foods. So to conclude, there are several factors other than diet that influence the development of hyperkalemia and chronic kidney disease. The data on the relationship between dietary potassium and serum is not consistent, but it's also weak. And dietary patterns that promote cardiorenal health are possible in people with kidney disease, and clinicians can use factors that influence serum and dietary potassium to limit the risk of hyperkalemia and chronic kidney disease. So now that I will turn it over to the next presentation.
Thank you. So I'm Dr. Spinowitz. You see my credentials, if you will. And in terms of disclosures, am I moving forward? Let's see. No? There we go. There are my disclosures. So let me just give you an overview of where I'm headed with this talk. I really would like to spend a fair amount of time describing the properties of the newer binders. I'll spend a little time discussing SPS, the old binder, because it really deserves very little time because there's very little data, as I'll describe to you. We'll talk about the mechanism of action of the new binders. They have slightly different mechanisms of actions that have some clinical consequences. And we'll talk about the comparative efficacy and the safety of these new binders. And then with each of those new binders, I'll show you some of the sampling of the data that's out there regarding the real-world data to show the impact of these binders on hyperkalemia. I'm going backwards. No, those are the disclosures. Let's see. There we go. So the risk factors for hyperkalemia, I think these have been touched on in the previous talks, but basically certainly underlying renal disease, and the worse the renal disease, the more likely one is to encounter hyperkalemia. Even absent that, just a baseline potassium greater than 4.5, even in the absence of any of the RAS blockers, is associated with the development of hyperkalemia. Underlying diseases, hypertension, heart failure, diabetes for various reasons, decreased blood flow, increased sodium reabsorption in the proximal tubule, absence of sufficient insulin, impacting transcellular movement of potassium. All of those comorbidities certainly contribute to the development of hyperkalemia. And certainly the use of medications. There are the potassium-sparing diuretics, but the biggest culprits, if you will, although they are critical for the management of our patients, are the RAS inhibitors. Increasing age, above the age of 50, we lose about 1% of renal function, so increased age certainly is a factor associated with development of hyperkalemia and dietary intake. And as has been mentioned, once hyperkalemia occurs, as you can see here, the next episode of hyperkalemia comes sooner, the frequency increases. So hyperkalemia, although it's measured intermittently, we consider that a chronic condition. And you'll see some of that data actually in the placebo-controlled trials of the newer binders, that with the removal of the binders, potassium returned right back up to baseline. Of course, ACE and ARB use is recommended, certainly in patients with underlying chronic kidney disease, with or without diabetes, with or without proteinuria, and the guidelines are changing somewhat, but certainly they're the cornerstone of therapies in patients with underlying renal disease, with or without diabetes. And I would mention right here that, one of the core studies that was mentioned earlier, the RENAL trial, the use of the ARBs in the setting there, diabetic nephropathy slowing progression, The impact was seen at maximal dose. In the case of Renala, was losartan. In the case of the iDent studies, irbesartan. Patients were maximally force titrated to the maximum dose of those ARBs, and it's in that context that the benefit was seen. And you'll see data shortly that submaximal doses are frequently used, and the fact of the matter is we don't know the impact in terms of slowing progression of the underlying comorbidity. The guidelines have been evolving, and certainly RAS use is critical in these settings. But as you can see, the strategies to control chronic hyperkalemia can include dietary restriction, discontinuation of potassium supplements, salt supplements, hyperkalemia-forming drugs, the addition of potassium-wasting diuretics if the patient is fluid overloaded, and finally, oral potassium binders make it into the recommendation. In previous guidelines, discontinuing or lowering RAS dosing was recommended. At least that has moved down, and the use of the newer binders has moved up in terms of the recommendations. But in the real world, this is a study done by Murray Epstein, a large database, and it's been alluded to with the previous speakers, that when you see the mild or moderate to severe hyperkalemia, the frequency of either lowering the dose or discontinuing the dose approaches 40 to 50%, depending on that level of potassium. And I think what this highlights is also, what is the definition of hyperkalemia? We see for epidemiologic purposes, it gets divided into mild, moderate, and severe. For me, hyperkalemia is a level of potassium at which the physician is going to either lower or discontinue the important therapies for the underlying comorbidities. So while mild hyperkalemia, a 5.2 wouldn't even make an H on your Quest lab slip. But I promise you, a 5.2, when the physician sees that, he's going to start thinking about, how do I lower my RAS inhibition? And that's not the next step that should be taken. And the impact of that has also been alluded to. While there's an association with mild and moderate hyperkalemia, severe hyperkalemia, and mortality, by the same token, these same patients in that study that had either decreases from maximal dose or discontinuations, you can see no matter what the underlying comorbidity is, heart failure, CKD, diabetes, that the impact in terms of mortality doubles and triples in these patients. So this is a direct relationship between the impact on RAS use in these patients as a consequence of the hyperkalemia, and in this case, the endpoint being mortality. So let me just turn to, we're now going to move to a description of the binders, but just as a polling question, all of the FDA-approved potassium binders, old or new, are likely to begin potassium binding in the false intestine. That's fantastic. Or is that just one vote? Who voted here? Okay. I'm giving away the answer. That's good. I don't know whether everyone's still eating dessert or voting. So why don't we move on? So in the next slide, 80% have gotten this right. So the next slide, the answer is there. Let me just sort of guide you through this. We're going to spend more time discussing patiromer and sodium zirconium cyclosilicate, which, if you don't mind, I'll refer to as SZC. Otherwise, I'm going to fumble over it. But just let me give you a little background about SPS, sodium polystyrene sulfonate. There's a calcium version that's common in the Middle East, Asian Rim. This appeared on the market, well, probably more than 50 years ago, prior to the FDA as we currently know it. In those days, drugs just had to exhibit safety. There was no notion of real efficacy studies as we're used to now with phase 1, 2, and 3 phase studies. So this really was grandfathered in. It's a non-specific cation binder. Some of the early data, it was given along with a cathartic, and it wasn't clear whether the cathartic was causing the colonic potassium loss as opposed to the binder SPS. The time to normal kalemia, that data wasn't done. Its onset of action is unknown, presumed to be in the colon, where potassium levels increased to about 40 milliequivalents, and now the competition that one sees with calcium and magnesium also binding with potentially SPS is overwhelmed by the potassium in the colon, so presumably the binding is in the colon. It may come as a surprise that just about the one and only study showing actual efficacy with SPS appeared in 2015, a 1-week study, 30 grams of Kayexalate versus placebo. So it does work without a binder, without a cathartic. But that's the extent of what we have in terms of controlled studies. In terms of safety and tolerability, clearly the GI side effects are legion. Other electrolyte disturbances can occur with use of SPS, particularly hypomagnesemia, since it does cause a nonspecific binding. In contrast, and I'm going to go into greater detail, Patiromer, another exchange resin, starts to work likely after 7 hours. I'll show you the data supporting that. Time to normalization of potassium level has been shown in controlled studies at 1 week. There is some restriction in terms of adsorption of other drugs with Patiromer, similar to Kayexalate, and so there's this window of 3 hours. Probably the site of action is in the distal colon, again, where potassium is elevated in concentration, as I mentioned for SPS, and there is reported hypomagnesemia and some GI side effects. SCC, you'll see, is a selective potassium binder. It's a crystal. It's not a resin. I will show you the data supporting its impact at 24 hours, and actually there's placebo-controlled data showing its efficacy at hour 1 after a first dose. There's a 2-hour window where other drugs should not be used because there is some impact on gastric pH, not because anything else is adsorbing to this crystal. It likely works in the entire intestine. That 1 hour onset of action is indicative of impact in the small intestine. There have been reported mild to moderate GI effects, and some edema has been reported, and I'll go into that in a bit of detail. So these are the two new binders. Let me start with Patiromer, which is a resin. It's calcium-based. Calcium is being exchanged ultimately in the colon, presumably for potassium. Most of that calcium is not absorbed. There haven't been any true balance studies. About 20% of the molecular weight of Patiromer is calcium. There have been small decreases in PTH noted in studies, but presumably that calcium is not bioavailable. Here, just remember this crystal structure for SCC with potassium stuck in the middle of that, and this 3 angstrom. The only thing that fits into this crystal is potassium, with one exception. I'll show you that when I get to SCC. So let's take a look at Patiromer. It's a polymer. Calcium is the counter ion, as I mentioned, an insoluble brown powder. It's not systemically absorbed, but other drugs can adsorb to it, and therefore that 2-hour window, and it does do some nonspecific binding, particularly with respect to magnesium within the colon. This is a phase 1 study that took a look at the onset of action. So this is a relatively small study, I believe about 25 patients. There was no placebo control. The patients were on a fixed potassium diet, and they were given the RLY is the original name, the Relipsa, for Patiromer. It was given twice a day at 8 grams for 48 hours. And as you can see, this is hour 4, this is hour 7. The hour 7 is statistically lower than the baseline potassium, and hence the notion that the impact in terms of serum potassium occurs at hour 7. The hour 4 decrement, since it's not placebo controlled, may be regression to the mean. And at the end of the 48 hours, there's been a decrement of potassium of 0.7 milliequivalents. So certainly efficacy, and this is a time-based course of impact. Phase 2 study, which is a critical study for patiromer, was Amethyst DN. It was actually a combination of efficacy of patiromer in the setting of diabetes with the intent of maximization of antihypertensive control, particularly with respect to ARB. And you can see patients with mild to moderate hyperkalemia were dosed with patiromer, and you can see that here, day 3, there is a statistically significant decrease. It's not placebo-controlled, but compared to baseline, and a maintenance of normal kalemia initially seen at week 1, and then this continuing for a 1-year study in these patients. And then with withdrawal, as I mentioned earlier, speaking to the chronicity of hyperkalemia, you see an increase in both of those groups towards hyperkalemia. And this is the core, this part of the core phase 3 trial that led to FDA approval of patiromer for the treatment of hyperkalemia. It was a 2-part trial. Part A was the first 4 weeks. This is just treated patients who are hyperkalemic, mild and moderate. You can see here the moderate, the mild, and all the patients. And you can see at week 1, there's a significant decrease to normal kalemia in patients that were treated with once daily patiromer. And that continues through the first 4 weeks. It met that primary efficacy endpoint of the first phase to say that there was a significant decrease in potassium from baseline, depending on the degree of severity. This was an increasing dosing trial, so patients were given either 8 up to 24 grams of patiromer. And the second part of that phase 3 trial was a withdrawal phase. So now you're looking at patiromer, potassium levels versus placebo, and you can see that the delta, the difference between the placebo and the patiromer group of patients was 0.7, statistically significant at week 8. Again, supporting the notion that this was a genuine treatment, placebo-controlled of hyperkalemic patients. The adverse event experience here in the uncontrolled, non-placebo phase, that first 4 weeks, there was some GI impact, but you can see in the placebo-controlled, it was relatively minimal. As noted, there was some hypomagnesemia seen in those patients. So all in all, a well-tolerated potassium binder that showed efficacy compared to a placebo. So let me move from the phase 1 through 3 trials to an array, and it's not an exhaustive exposition, but an array of real-world trials of the impact of this particular binder in patients with hyperkalemia, with underlying comorbidities, who are taking, in fact, RAS inhibitors. So this is the first study, and I remember reviewing this with my fellows in Journal Club. We were really thrilled to see the introduction of a effective, well-tolerated binder, although this was in the heart failure arena. So the objective here was optimization of mineralocorticoid receptor antagonist therapy in patients with heart failure using patiromer versus placebo. So these were heart failure patients, age greater than 18, clinically indicated to have spironolactone, whose potassium was between 4.3 and 5.1, and had some degree of renal dysfunction and were on a RAS inhibition, or they had documented hyperkalemia and the RAS inhibitor had been stopped. And you can see clearly here, spironolactone was initiated at 25 milligrams per day, increased to 50 after 2 weeks. So this is a forced titration of appropriate therapy for HFrEF, for reduced ejection fraction heart failure. And you can see the spread, potassium well maintained in the Relipsa, patiromer-treated group, as opposed to the placebo group. This is the first hint of the kind of impact that a well-tolerated effective binder could have in patients with these underlying comorbidities who are on the appropriate therapies. Another more recent study, the AMBER study, Also looked at the impact of patiromer on appropriate therapy. In this case, it was patients with resistant hypertension. Resistant hypertension are patients who were uncontrolled with 3 different classes of antihypertensives or controlled with 4 different classes of antihypertensives. So it's a difficult group of patients to manage. And very often, certainly ACE or ARBs are part of that regimen. But increasingly, we've come to understand that MRAs, aldosterone blockers, are an important part of treating these resistant hypertensives. And that's what this study looked at. So these were almost 300 patients with underlying CKD, resistant hypertension, eGFRs as shown here, 25 to 45, upper limits of normal of serum potassium, and they were then randomized to receive either spironolactone with or without patiromer. This was a titration of patiromer from 8.4 per day, increasing as needed, but patients were started at spironolactone 25, and then at week 3 were moved up to 50 milligrams of spironolactone. And the endpoint was how many of these patients tolerated this appropriate therapy for their resistant hypertension, and what were the potassiums that ensued. And as you can see, the time to serum potassium greater than 5.5. Significant increase, much higher in the placebo group compared to those that were treated with patiromer. And the flip side of that is the time to discontinuation of spironolactone. And you can see that about 85% of patients continued on the spironolactone with patiromer, as opposed to, about 65% or so. So a significant difference in the appearance of hyperkalemia in the placebo group, and a larger number of patients who were able to achieve the appropriate treatment for resistant hypertension. It didn't show a difference in blood pressure because everyone was getting the spironolactone. So small differences in blood pressure. All of the patients did have a decrease in blood pressure, as is expected, of about 10 millimeters. But certainly there was impact on the ability to continue using the appropriate therapy for the resistant hypertension. One more study called the DIAMOND study. And here the intent was to look at something other than a binder, in this case patiromer, as a permissive agent, if you will. And I was going to look at another endpoint, and that is cardiovascular endpoints in patients with underlying HFrEF, reduced ejection fraction, heart failure. And the original intent of this large study was to look at cardiovascular events, cardiovascular death, hospitalization for heart failure in those patients that were optimized to treat their therapy using RAS inhibition, as should be the case with HFrEF. After all, those patients, the recommendation there is a beta blocker, which has some impact, as was mentioned earlier, in terms of transcellular movement of potassium, certainly an ACE or an ARB, and the addition of an MRA. So the therapy is optimally triple therapy. They're having impacts on potassium levels. So it's a very important study. And it was going to be placebo-controlled, patiromer versus placebo. Unfortunately, this study was done as COVID occurred, and that endpoint was changed. And it was, unfortunately, the endpoint, while was a patient-level outcome impact on cardiovascular events, ultimately turned into, again, what's the impact on potassium level, and whether more patients could be optimally treated if on patiromer versus placebo. And you see that data here. There was a significant difference in the placebo, in the potassium levels in the placebo versus the patiromer patients. And there were increased numbers of patients who were able to have the maximum therapy with an MRA. You can see the reduction in MRA was lower with the treated versus the placebo, and serum potassium levels greater than 5.5 were lower in the treated, patiromer treated versus placebo. So that was the conclusions, but unfortunately, it did not was not robust enough to answer the question about impact on cardiovascular outcomes. The real-world evaluation of patiromer in the setting of hyperkalemia. This is a retrospective study from a large dialysis organization, patients who were treated with patiromer once a day with hyperkalemia in the dialysis setting. and after patiromer, improved levels of potassium. So let me turn to SCC, mechanism of action. I showed you the crystal before and the interatomic distance in that crystal of being just 3 angstroms. And you can see potassium, as opposed to sodium or calcium, magnesium, those other cations will not fit into this crystal, and so there was no competition. The only other thing that fits into that crystal happens to be ammonium, and actually in the clinical studies there has been an increase in serum bicarbonate, and that's probably due to the ammonium trapping. That's the mechanism of action. Let me show you the detailed data. So this progression of the 3 main phase 3 studies with SCC were a 14-day study, subsequently a 28-day study with a 1-year extension on some of those, and then a full 1-year safety study. And you can see that here, and it's not shown, but this is placebo-controlled. So, oops, let me go back. It's important. So this is the first 48 hours. The core studies all had a 48-hour period where the dosing was 3 times a day at 0, 4, and 10 hours, and then again at 24, 4 hours later, 10 hours later. So 6 doses in the first 48 hours, and then daily dosing thereafter. You can see here, so this is the mean of 5.3. These first 3 dots are after that first dose. The caret is shown here. After that first dose of Lokelma, in this case 10 grams, you can see statistically significant decreases, and that was placebo-controlled. So at hour 1, you've got a significant decrease in potassium with that first dose of SCC. And hence we think the mechanism of action is binding starting at the small intestine. You can see that normalization of potassium through the first 48 hours, and here versus placebo, the 10-gram dosing daily, maintenance of normal kalemia throughout that first 14 days off drug, again, movement back to hyperkalemia. Moving to the next study, this was a longer study. There was a 48-hour correction. That first 48 hours in this case also TID dosing, not placebo-controlled, because there were no upper limits to the serum potassium. These are outpatient studies. No impact on diet was recommended. No changes in RAS using was recommended. And so in this first 48 hours, again, TID dosing of 10 grams, and then patients were randomized to placebo or various dosing. And at the end of 28 days, about half of those patients had an extension study for 1 year. And the data shown here, similar to data which I showed you before, a decrease here, that mean potassium was higher, 5.6. There were no upper limits to the patient's hyperkalemia coming in and going into the study. There were normalized decreases seen again at the first hour, at 48 hours, normalization of potassium, and you can see versus placebo on the top. This is 2 different doses, the 5 and the 10 gram, now done daily, and the extension for 1 year showing maintenance of normal kalemia. End of dosing, return to hyperkalemia in these patients. When you look at the subgroup analysis, this is in the first 48 hours with that 10 dosing, comparable decreases in potassium from the mid-5s seen in patients with CKD, heart failure, diabetes, those taking RAS inhibition. About 75% of the patients in the study were on RAS dosing. And another interesting feature of SCC is that this is the impact, absolute decrement in potassium with the 10-gram dose given 3 times a day for 2 days. So all these people got the same dose, but the higher ambient potassium, the greater is the absolute decrement in potassium level. It's the ability of this trapping of potassium by SCC. And this is the data from the 1-year safety study. Here, patients with hyperkalemia were given TID dosing of 10 grams of SCC. They came back 24 hours later. If they were normalized their potassium, they were introduced into the 1-year study. If not, they were given another day of TID dosing. About 85% of patients normalized after the first day on 10 TID. And then this is the data at 1 year, maintenance, mean maintenance of potassium. And one of the important points of this is that of these 750 or so patients, 483 were on RAS dosing. There was no recommendation about RAS decrement or changing, et cetera. And you can see that 3/4 of those patients maintained their RAS dosing. Some had increases, some had some decreases, some had both. But the vast majority of the patients were able to be maintained on their RAS dosing with no recommendations in terms of dietary restrictions. And this is a 1-year study. And again, removal of the drug back towards hyperkalemia. One of the side effects that is listed is the development of edema, which is still a relatively rare event, particularly at the higher dose of SZC. It is a sodium-based crystal. Again, no balanced studies have been done, but you do have to be aware of the development of edema. In the clinical trial, half of the patients had a resolution of the edema without any change. Others required a change in their diuretics. So something that you do have to be aware of, particularly in the patients who have associated CKD along with heart failure when SCC is used. Now to move quickly into just a sampling of the real-world studies. This is the optimized study, which shown here again. These are patients with underlying renal disease or heart failure that may require RAS dosing, and what is the impact in terms of RAS dosing as you go through the year time in the real world. And you can see on the upper line is the data from that 005 study that I showed you. It was part of the phase 3 trials. But you can see the real world data is very comparable. That is to say, in the range of 65 to 70% of patients were able to maintain their RAS dosing. And again, this is real world data, not study data. This was an attempt to also look at the impact of SCC in the heart failure arena with the intent of looking at heart failure outcomes. Unfortunately, that study too had to be terminated early, and I'll draw your attention to just one area. So this is patients with heart failure, and the objective here was to see, was originally to see impacts in terms of cardiovascular events, but here gathered are just those percentage of patients who have various therapeutic impacts on their heart failure, whether it be ACE use, ARNI use, MRA at less than target dose, and the optimal would be the addition of MRA at target dose. And you could see that there was a slightly higher frequency of those patients on SCC that were able to achieve the more optimal therapy for heart failure. But again, the difficulty encountered in doing one of these patient-level outcome studies rather than just looking at the impact on either potassium and the use of optimal therapy for comorbidities. And with this last study, the dialyze study, this was a study that was placebo-controlled, looking at the potential utility of SCC in the dialysis population. This was about a 200-patient study. Patients on dialysis, TIW, who had pre-dialysis hyperkalemia after their long interval, Mondays or Tuesdays. They were randomized to receive SCC at starting doses of 5 up to 15 grams. There was a titration period of 4 weeks versus placebo. And then there was a maintenance of whatever that dose of SCC versus placebo was at the end of 4 weeks for an additional 4 weeks. And the intent was, how often can you achieve normal kalemia after a long dialysis interval in patients who were previously hyperkalemic on 3 out of their 4 long intervals. And the data was impressive. About 40% of patients on SCC were able to achieve that goal versus none in the placebo. And this just gives a sort of a sense of the hyperkalemia. So this is patients hyperkalemic in the screening phase after their long interval, short interval potassium. And you can see here the placebo in gray, pretty much maintenance of hyperkalemia pre-dialysis, as opposed to the pre-dialysis potassiums both after long interval and short interval in those patients who were treated with SCC. And the importance of this, I think, was alluded to in one of the other talks. Patients coming to dialysis hyperkalemic, that in itself is a risk of arrhythmias. There is an increased incidence of death in the dialysis patients on the Mondays and Tuesdays that may be multifactorial, potassium, volume overload, et cetera. but it's also that delta. When we dialyze patients, and now pretty much everybody dialyzes against a 2K bath. The 1K bath is verboten. But that delta, hyperkalemia versus the dialysate bath, there's a very rapid drop in potassium, as was shown. And that's arrhythmogenic. Volume is coming off, magnesium is coming off. There are other causes for the arrhythmogenicity of the dialytic process. But it would certainly be better to have patients coming in closer to normal kalemia and allowance for the dialysate bath to be raised perhaps even to 3 milliequivalents, so that that delta is minimized. And that's one of the important potential patient endpoints, but that wasn't looked at here. We simply looked at potassium, impact on potassium in this dialysis setting, placebo-controlled. So, rethinking hyperkalemia to optimize RAS inhibition therapy with the binders. So hyperkalemia, I think we've shown you, is frequent, it's recurrent, it's really chronic. It's associated with the various comorbidities that we're all aware of, particularly with the appropriate therapies for those comorbidities. Hyperkalemia, I don't think I showed you or anyone shown, we've shown you mortality increases, but it's not only just hyperkalemia associated with patient outcomes, there's an increase in healthcare resource utilization. And rechallenging with RAS therapy does not consistently have had occurs. The reality is that once appropriate therapy for comorbidity is discontinued, very often it doesn't get restarted, and that certainly has an impact on outcomes. And the treatment guidelines certainly are changing, they're evolving. The use of the binders has been moved up in terms of consideration. I think in all fairness to the guideline creators, the pure study of what the impact of lowering potassium has, it can be debated based on the studies we've seen. Certainly potassium gets lowered, but what's happening in terms of outcomes is RAS inhibition is used as the endpoint that we move to rather than the patient level outcomes. So as a consequence, they don't get quite the high recommendation that guidelines frequently give, but there's no question that they've had a significant impact on the management of our patients and allowing for the uses of appropriate therapy for the underlying comorbidities that we see in our patients. So with that, I'll close. I think we've got time, even though I've gone over time. I apologize, but I think we have time for questions. Thank you.
Thank you. I do have the questions that are on the app, but if somebody also would like to come up, we're more than happy to answer questions at the microphone. But I will start with one of the questions is, just Anna, have you had issues with type 1 diabetes patients with gastroparesis and incorporating fiber in their diets?
Good question. So the recommendation that I mentioned about using viscous fibers, particularly for the management that may enhance, particularly through increasing the fecal output, probably is not very useful for a person with gastroparesis because it's probably going to be the opposite effect that we want. So I am currently not practicing, but I am hoping to hopefully get some information from current clinical and practicing dietitians if they have implementing specific fibers. Things to consider here, obviously, all of the factors that are related to type 1 diabetes management, obviously adequate insulin dosing that could also enhance the uptake, and other types of therapies that you could use for those patients.
Okay. No? Okay. And then I am going to try to, so to Bruce, is it counterintuitive to use a sodium-based potassium binder in heart failure?
So the question is whether it's acceptable. So again, sodium, I didn't show you the formula. Most of the counter iron is actually hydronium iron. There is about 10% sodium content. SEC, folks never did the full balance study. That is to say, you would have liked to have known in the course of the study, how much sodium came in, measure how much goes out in the urine, how much comes out in the feces, and then the presumption was that that excess or that difference would have gone into the body. So we used surrogate markers, namely edema. As I indicated, the edema that we saw in the controlled studies was predominantly in the 15-gram dose, and it turns out that only about 5 to 10% of patients require a 15-gram dose per day. We did not see it at all in the 5 and just a little bit in the 10-gram dose. And the edema that was described in the course of the studies, I've done studies where we worry about edema and we have to decide 1 plus 2 plus 3 plus 4 plus, and it's rigorous. In this case, it was just the physician investigated notation of edema. And again, relatively minimal, but then we looked at this, at what the consequence of that was, and half the time there was no change in the diuretic, so it starts to question how much edema there was. In terms of any serious volume overload, there was only 1 case in all the placebo trials where a patient was admitted for pulmonary edema, and it was probably the consequence of other things. So the reality is that we don't think much sodium is absorbed. There was one small phase 2 study that did look at balance, and it turns out that the potassium, the sodium excretion was not increased after 48 hours of dosing with SZC. So that's really the data. So in terms of, the counterintuitive, the sodium is there. The presumption is it doesn't come out. And the exchange, it's really not an exchange as much as potassium is just trapped into that crystal, and more of it probably happens in exchange for hydronium ion. As a matter of fact, there's a gastric pH change with SCC. So from a clinical point of view, it's something that you should be aware of, watch for, but I wouldn't describe it as counterintuitive.
Regarding potassium binders, can you comment on dosing only on non-dialysis days? We've had some success dosing in this manner. I think Bruce might be aware of the study. I do that as well. I dose it. It actually, for my patients, we decrease the amount of pre-dialysis hyperkalemia, but we also tell our patients that it helps liberalize what is a very restrictive diet. Do you know the study data? I'm not sure.
Yeah, again, in the dialyzed study, which is a rigorous placebo-controlled study, we dialyzed, I'm sorry if I didn't mention, we dialyzed them, we dosed on non-dialysis days only. We did not dose on dialysis days. And you saw the results. That was both dialysis days and after long intervals, short intervals, in the patients who were treated in that fashion, they came in with lower potassium levels, but it's non-dialysis days only. The patiromer data, which was retrospective data, they were dosing on a daily basis with patiromer.
So people are asking about binder. I don't have any. I work at the VA, so I know nothing about pediatrics. But someone's asking if they know there's any pediatric data. Are you aware of any?
The answer is no. And in fact, in our hospital, where SCC is the main formulary, SPS still stays on board for parenteral use or pediatric use. So my guess is there is not official pediatric data as exists with many drugs.
I'm a pediatric clinician, and I want to make a comment on that. There was one small study decanting formula with patiromer, which is something that's a practice that's common with SPS as well. It's falling out of favor now because we have better modulating formulas, but there was one small study looking at using it, but just for decanting formula. So just a fun fact.
Thank you for that.
Yeah.
Does anybody else pediatric experience? I mean, as I said, unfortunately, I do not. Okay, so moving on. People ask what is the maximum dose for SZC and what is it determined by? I think there's that first 48 hours of 10 TID. I use 5 to 10 grams a day, so 10 would be my maximum. Do you use more?
Yeah, so it's again, in the studies, only about 5 to 7% of patients required 15 grams. In Europe, I would add that the 15 grams dose is off. The max dose in Europe is 10 grams. But fortunately, the vast majority of patients can be controlled with 5 or 10. As a matter of fact, we had about 5 or 7% in that long last study that I showed you who were maintained at 5 every other day. Which in clinical practice occasionally I use. So it's a rare patient that I see that needs 15 grams for maintenance, but this 10 TID is very important because that's what we have the data on. I stress this in the hospital. My fellows get called for hyperkalemia in the middle of the night. Fortunately, with SCC, because it starts to work so quickly, we have fewer emergency dialysis treatments, but I can't overemphasize enough. Do that 3 times a day dosing to start. And if you want to be strict, go by the studies. We did it at 0 time, 4 hours, and 10 hours. That's the sequence of the 10-gram dosing. To get normalization, we've got the data on that. Granted, it was outpatient data, not hospital data, but that's what I would recommend. But the 15 grams is fairly unusual.
So, for Annabelle, while clearly impacting potassium content, to what extent do wet cooking methods decrease other desirable nutrients?
I think that's a really good question. So there are several factors that are going to affect the bioaccessibility of not only potassium, but also phosphorus. Thinking, for example, in the context of wet cooking methods, using beans as an example. So these are high phytate content foods that may be having some of the phosphorus associated with it, and the concentration could be lower to 50%. But phytate also binds other nutrients, including calcium, magnesium, zinc, and iron. So if we are limiting or leaching some of those nutrients, does that mean that the nutrient quality of those foods is limited? And the actual evidence, we really don't have data on how it may impact other nutrients that are relevant. So to answer the question is we do not have. Probably it does impact because it may be leaching not only potassium and phosphorus, but it's also probably also leaching other nutrients that are important.
So let's say practical, for a patient who comes into the office with a potassium of 6, is it still of little to no benefit to stress a low potassium diet?
I think first thing, and probably all dietitians probably are doing this, but assessment. How really your patient is eating. Like, is dietary potassium driving some of these, or are there any other factors that are probably affecting that serum potassium? Is there a low appetite that may be driving more muscle wasting, that may be driving more potassium in blood? Is there insulin resistance? Is there, if they take insulin, if they are not moving enough? So all of these factors probably will be assessed in a regular dietary assessment, but I would say that it will only depend on that individual. It's not that you automatically will give a low potassium diet for a patient with a 6. It's assessing if potassium is actually in fact a driver of that, or at least that would be what I would do.
So, Bruce, I'm going to ask you as a practical thing, if somebody comes in with a potassium of 6 and you're going to start them, let's say, on a binder, do you also do a low potassium diet at the same time, or an assessment, dietitian?
Well, there are a few things. First of all, I would caution, and I don't mean to be a hyperkalemia cynic, but please remember, tourniquet, fist pumping, New England Journal of Medicine, 0.3 to 0.4 milliequivalent increase in potassium, just that process. So it's very important to get a repeat level. but when you've got a 6 in front of you, it's reasonable to respect it. Although typically if someone appears with a 6, I'm very often looking at a lab test that's 2 weeks old and the patient's there. So I feel fairly comfortable. So a repeat is critical. Plasma potassium, I encourage my medical assistants, try to put the needle in, take the tourniquet off, no fist pumping, and then we see that potassium. But that's a patient who's going to go home on Lokelma. And in terms of dietary approaches, my own approach is that I look for what I would consider excess potassium intake, that which we can do away with. You know, if someone's drinking orange juice, you know, big glass every week because they think the vitamin C is going to make them live forever, that's something that you can adjust. You know, perhaps 2 ounces of dry pasta with just a little bit of sauce instead of 2 bowls. So I try to look to limit the excess of potassium, but the reality is I find that altering their diet as an approach or as the sole approach is quite difficult for patients, so binders feature into it. But please take that first step. Make sure that we're dealing with true potassium elevations.
So I will also remember to comment about the low salt, the salt supplements, because I had a patient we did that where we recommended that they decrease salt in their diet because they had edema and hypertension, and then the next thing we knew they had a potassium of 6.5 because they went and got the potassium supplements. I will turn over to Annabelle to finish the last thing, but I do, when somebody had pointed out that patiromer has a pediatric indication for ages 12 to 17. And I'm going to let you comment on what we were just talking about, and then that's going to be our last question.
Yeah, so there's been a small, relatively small study that actually studied the impact of liberalizing dietary potassium with the use of potassium binders. And they were using that maximum dose, and they went from a very low potassium diet of, I think it was like 2 grams per day to all the way to 37 milligrams per day. And it was mostly from plant-based foods. And most of them even, I mean, they were using the maximal dose, but they were able to liberalize to 37 milligrams using fruits, vegetables, whole grains, nuts, seeds, all of the things that we're trying to promote as a healthy diet. And this was done in Stockholm. But it was not a randomized control trial, but a feasibility intervention study.
I think we're a couple minutes over. I want to thank everybody who stayed, and thank you for your attention.